In this video, we're going to go over the three-compartment model of the lungs. To briefly recap, in the previous video, we used the ideal alveolus model of the lungs, and the key takeaway messages were that alveolar PO2 is equal to arterial PO2, end-tidal CO2 is equal to arterial CO2, and that oxygen content in the blood relates mainly to the hemoglobin saturation, because dissolved oxygen is not very significant. All of those key points are wrong. Arterial PO2 is not equal to alveolar PO2, it's usually slightly lower. And end-tidal CO2 is not equal to arterial CO2, it's also usually slightly lower. And dissolved oxygen is very significant when we're looking at the response of shunt to supplemental oxygen. So does that mean that everything that we learned in the previous video is invalid? Fortunately not. It just means that we've reached the limitations of what that model can explain, and we now need to use a more sophisticated, robust model to explain these new observations. And so this more sophisticated model is the three-compartment model of the lungs. So in this model, we keep the ideal alveolus that we had before, but we add two other types of alveoli. So we add an alveolus that is ventilated but not perfused, and we also add an alveolus that's perfused but not ventilated. We also need to recognize that the capnograph isn't a perfect square wave, that phase 2 and phase 3 tend to be slightly upsloping, and we need to be able to explain this shape. The next concept that we need to be very clear about is dead space. The general definition of dead space is that it's the part of the tidal volume that does not participate in gas exchange. Let's use the three-compartment model to look at exactly where that is. Let's consider an intubated patient and think about, during inspiration, where does that tidal volume actually go? Well, by definition, this shunted alveolus doesn't receive any ventilation, so I've just moved the obstruction up a bit higher to make that clear. And so the tidal volume is going to distribute to all of the other areas, all of these colored areas. Now, within these areas, where is gas exchange occurring? Well, the only place that gas exchange is occurring is in this ideal alveolus, because clearly no gas exchange is going to occur in the ET tube. The conducting airways aren't designed to gas exchange. This alveolus is supposed to be gas exchanging, but because there's no blood flow going past it, it has no blood to exchange gas with. So this gives us the three different types of dead space. Anatomical dead space is defined as the volume in the conducting airways, while alveolar dead space is defined as the part of the tidal volume that passes through the conducting airways to mix with gas at the alveolar level, but which does not participate in gas exchange. So that's a bit of a wordy definition, and I've taken that straight out of Nunn's, and I think Brandis also uses the same definition. But it really appeals to me because it's very precise in telling you exactly where it is. If we look back at our three-compartment model, it's saying that the alveolar dead space is the part of the tidal volume that passes through the conducting airways to mix with gas at the alveolar level, but which does not participate in gas exchange. But if you don't like that definition, you can just go with the simpler definition that it's alveoli that are ventilated but not perfused. And you can also say that this corresponds to West Zone 1. Physiological dead space is the sum of all the parts of the tidal volume that do not participate in gas exchange, i.e. the total dead space, anatomical plus alveolar. Now, apparatus or equipment dead space, some people have a bit of confusion regarding this. The definition is that it's the part of the breathing circuit where to and fro movement of gas and rebreathing of expired gas occurs. So if we consider a circle circuit, a common error is for people to say that the entire circle circuit is dead space. But if we go back to our definition, it's where to and fro movement of gas occurs. And the only part of the circle circuit where to and fro movement of gas occurs is distal to the Y patient connector. So this is the only part of the circuit where the patient can rebreathe expired gas. As long as your one-way valves are working correctly, the flow through the circle circuit is in unidirectional only. And if we look at the T piece, it's a bit more complicated because the dead space will depend on the fresh gas flow. If there's a high adequate fresh gas flow, then the only place where rebreathing of the expired gas occurs is from the part that's distal to that fresh gas inlet. Whereas if the fresh gas flow is inadequate and too low, then there can be rebreathing of expired gas from the entire circuit.
This is a very busy slide, but I only want to use it to discuss 2 points. The first thing is we want to understand why West Zone 1 is alveolar dead space, and the second thing is to understand why perfusion increases going from the apex to the base in the upright position. Now, pulmonary artery pressure is generally quoted to be 25/8 with a mean of 15, and we'll just consider the mean to keep things simple. And I've never seen a textbook that tells me the pulmonary venous pressures, but it must be very similar to left atrial pressure, so I've put it as 5, just so that we have nice numbers to work with, and our driving pressure is 10. A textbook lung is 30 centimeters tall, and again, to keep things nice and simple, let's assume that the heart is right in the middle of the lungs, which means that the apex is 15 centimeters above the level of the heart. And due to the effects of gravity on hydrostatic pressure, this means that the vascular pressures will be 15 centimeters of water lower, which is equivalent to 11 millimeters of mercury. So from this analysis, we can see that there's just enough pressure to perfuse the apical alveoli. So in the healthy lung, there is no West Zone 1 where there's no perfusion. What is West Zone 1? As we know, it's defined as when the alveolar pressure is greater than the arterial pressure, which is greater than the venous pressure. And when would we get West Zone 1 then? Well, anything that's going to be associated with reduced arterial pressures will cause West Zone 1. Really anything that causes shock, or alternatively anything that increases the alveolar pressure, for example, the use of high PEEP. And because the intraalveolar capillary is exposed to the alveolar pressure outside of it, if the alveolar pressure is greater than the intravascular pressures, this is going to mean that the capillary is completely compressed and occluded, and there's not going to be any blood flow. So this alveolus would get ventilation but not perfusion, making it alveolar dead space, and this is why we say that West Zone 1 is alveolar dead space. The next thing to understand is why perfusion increases going from the apex to the base. And the common response to this question is to say that because of the effects of gravity going towards the base, there's an increase in perfusion pressure, and that's what causes the increase in blood flow. And this is generally followed on by a description of the different West zones. Now, this answer is probably not going to score particularly well because the mechanism given is incorrect, and secondly, the West zones are a little bit incidental to answering the question. They're more of a consequence of perfusion increasing from the apex to the base rather than causing the increase in perfusion. So where is the flaw in the logic? Well, if we consider going from the level of the heart to the base, yes, because of gravity, the arterial pressure is increased by 11 to 26, but the venous side, the pressures are also equivalently increased because of the effects of gravity, and therefore the driving pressure is unchanged, it's still 10. So there is no change in the driving pressure going from the apex to the base. The perfusion increases as a result of increasing recruitment and distension. So recruitment is occurring mainly in West Zone 1 and 2 and refers to the opening up of previously collapsed capillaries. So we can see that at the apex, if there's any collapsed capillaries, then going down towards the base, when the intravascular pressures are increasing, they're going to open up because they are starting to exceed the surrounding alveolar pressure. And since these capillaries are in parallel to the existing pathways for flow, it's going to reduce the vascular resistance. And distension is occurring mainly in West Zone 3, where the increasing intravascular pressures going towards the base will distend the capillaries, increase their radius, and therefore reduce their vascular resistance. So the increase in blood flow doesn't have to do with a change in perfusion pressure. It has to do with a reduction in vascular resistance. And so we're applying this concept regionally, going from the apex to the base, but it also applies to the lungs as a whole. And this is why, as pulmonary artery pressure increases, it's associated with a reduction in pulmonary vascular resistance because of increasing recruitment and distension. The arterial to end tidal CO2 difference is a very commonly asked question. To understand it, let's look at the volume capnograph, which plots PCO2 against the expired volume. So the shape of the graph is very similar to the time capnograph that we're more familiar with, the difference being that there's no inspiratory phase, it just finishes at the end of expiration. And secondly, it tends to be more sensitive in displaying any subtle changes due to VQ inequality. Let's consider what's happening on expiration. So we're sampling gas at the mouth, and so the first gas that's going to be sampled on expiration is the apparatus dead space gas, which doesn't contain any CO2, followed by the anatomical dead space gas, which also doesn't contain CO2. So that gives us phase 1 of our trace. And following the anatomical dead space gas, it's going to be the ideal alveolar gas and the alveolar dead space gas that's coming out at the same time. Now, if there were no alveolar dead space present, then it would all be ideal alveolar gas coming out, which has a PCO2 of 40. So in phase 3, our trace would go up to 40, which would be the same as the arterial value. But if there is any alveolar dead space present, because this gas does not contain any CO2, when it mixes together with the alveolar gas, it's going to dilute the CO2 concentration and lower the value in phase 3. So the more alveolar dead space there is, the lower that value is going to be, and the greater the arterial to end tidal CO2 difference. And this is why we say that the arterial to end tidal CO2 difference gives us an index of how much alveolar dead space is present. We should also recognize that the capnograph trace is actually not a perfect square wave, that phase 2 is slightly gradated and phase 3 is slightly upsloping, and we should be able to explain this appearance. Phase 2 is the transition between anatomical dead space gas and alveolar gas, and there are 3 reasons why that transition isn't completely abrupt. The first reason relates to the spatial arrangement of alveoli. So the alveoli that are located close to the hilum, the gas will reach the mouth earlier than the alveolar gas that's coming from the more peripheral alveoli. And so that's the first reason that contributes to this appearance. The second reason relates to heterogeneity of time constants of the alveoli. We're going to talk more about that in the third video, but for the moment, we just say that fast alveoli will empty before slow alveoli. And heterogeneity of time constants also is what causes the upsloping in phase 3. The third reason has to do with the characteristics of laminar flow. So flow in the airways is a combination of turbulent flow and laminar flow. And one of the characteristics of laminar flow is that the velocity in the central stream is faster than at the peripheries. So what that means is that even if you were to start with a very clear-cut delineation between alveolar gas that contains CO2 and dead space gas that does not contain CO2, as soon as there's airflow and movement of that interface, there's going to be blurring of the boundaries, and this will also contribute to this gradated appearance. To recap the important points, We expect that end-tidal CO2 will be equal to arterial CO2 because end-tidal CO2 represents alveolar CO2 and transfer across the alveolar membrane is perfusion limited. However, end-tidal CO2 is usually slightly lower than arterial, and this can be explained by a small amount of alveolar dead space. In alveolar dead space, there's no gas exchange occurring, which means that it will contain no CO2. So when it mixes with the rest of the alveolar gas, it will dilute the CO2 concentration. And hence, the arterial to end-tidal CO2 difference will give us an index of how much alveolar dead space is present.
Anatomical dead space is measured using Fowler's method, which is a single-breath nitrogen washout technique, where the subject breathes in 100% oxygen and all of the nitrogen that's present within the lungs is moved distally into the alveoli, so that at the end of inspiration, the nitrogen is only present within the alveoli, just like how CO2 is only present within the alveoli. And this is why on expiration, when nitrogen concentration is plotted against expired volume, we get a resultant trace that is very similar to the volume Kapner graph, where phase 2 represents the transition between anatomical dead space gas and alveolar gas, and phase 2 is sloped for exactly the same reasons. The way that anatomical dead space is now calculated is by drawing a straight line through the slope of phase 3 and then a vertical line through phase 2, such that the areas of these roughly triangular areas A and B are equal. And we take this to be the exact transition point between anatomical dead space and alveolar gas. So I'm not sure if there's a mathematical reason why this is the method that's used or whether it's a pragmatic reason. But in the exam, you should be able to reproduce this diagram and explain how it's performed. Physiological dead space is measured using the Bohr equation, and you should be able to quote this equation in the exam, which states that the dead space volume divided by tidal volume is equal to alveolar PCO2 minus mixed expired PCO2 divided by alveolar PCO2. And so the subject was asked to expire, and the expired gas was collected and sent off for analysis to get this value of mixed expired CO2. But also a small part of the end expiratory gas was collected separately and sent off for analysis, which would give what we would now call the end-tidal CO2, and that value was used to substitute in for the alveolar PCO2. Once ABG analysis technology became available, Enghoff proposed a modification where the arterial PCO2 was substituted for the alveolar PCO2. Alveolar dead space can be calculated by measuring both the physiological and anatomical dead space and then taking the difference, or alternatively, a further modification of the Bohr equation can be used, where end-tidal CO2 is substituted for this term here. And as we can see, the numerator is just the arterial minus end-tidal CO2, which agrees with what we said before, that the arterial to end-tidal CO2 difference gives us an index of alveolar dead space, and this just puts it into a mathematical formula. Is dead space just one of those things that they make you learn for the exam, or is it actually relevant to clinical anesthesia? Well, I would say that it's very relevant to clinical practice, and we should keep in mind that dead space ventilation is wasted ventilation. The first part of the inspired tidal volume has to pass through the anatomical dead space before reaching the alveoli, so if the tidal volume is small, it's going to be mostly wasted ventilation. And we can think of apparatus dead space as an extension of anatomical dead space, and this becomes proportionally more significant the smaller the patient. And I think the most significant type of dead space for clinical practice is alveolar dead space. And we should recognize if we have a sudden drop in end-tidal CO2, what does that indicate? It means that there's been a sudden creation of a lot of alveolar dead space, which has then increased the arterial to end-tidal CO2 difference, resulting in this sudden drop in end-tidal CO2. and this generally indicates that there's been a sudden reduction in pulmonary perfusion pressures, which means that the patient has suddenly lost cardiac output and something bad has just happened. We now move on to the concept of shunt. Shunt is venous blood which enters the arterial system without passing through the gas-exchanging parts of the lung. In our three-compartment model, it's mixed venous blood that's flowing past an alveolus that's not getting any ventilation, which means that no gas exchange occurs and the composition remains the same. It's still deoxygenated mixed venous blood, and it then combines with the oxygenated blood going past the ideal alveolus, and that becomes the systemic arterial blood. Shunt is measured by the Shunt equation, which is essentially an expression of the law of conservation of mass. It's essentially saying that the amount of oxygen that's flowing through here, the arterial blood, must equal to the amount of oxygen that's flowing through here, the non-shunt fraction, plus the amount of oxygen that's flowing through here, the shunt fraction. And so we start off with this equation, which we can then rearrange to solve for the shunt fraction. And that's equal to the oxygen content in the pulmonary end capillary blood, which refers to the blood flowing past the ideal alveolus, minus the content in the arterial blood, divided by the content of the pulmonary end capillary blood, minus the mixed venous blood. And this is an equation that you should be able to quote in the exam. It's quite intuitive to understand how shunt can cause hypoxaemia. That the blood flowing through the shunt fraction is deoxygenated venous blood with a low oxygen content, so when it mixes with the pulmonary end capillary blood, it will dilute the oxygen content. Now, if there weren't any shunt present, then the arterial PO2 would simply be the same as what's in pulmonary end capillary blood, which is equilibrated with the ideal alveolar gas, and there would be no difference between the arterial PO2 and the alveolar PO2 as calculated by the alveolar gas equation. But the presence of a shunt would reduce the arterial PO2, and this is why we say that the AA gradient gives us an index of how much shunt is present. In the exam, you should be able to reproduce the iso-shunt diagram and explain why at low levels of shunt, the hypoxaemia will correct by giving supplemental oxygen, but as the shunt fraction increases, there's less and less of a response, such that once the shunt fraction exceeds 30%, we are no longer able to correct the hypoxaemia even giving 100% oxygen. To understand this pattern of response to giving supplemental oxygen, we need to look at the effects on both the non-shunt fraction and the shunt fraction. We'll start with the non-shunt fraction. Previously, we'd said that increasing the PO2 over 100 didn't significantly increase the oxygen content, but we need to look at that a bit more precisely now by using the oxygen content equation. Now, according to Brandis, when PO2 is 100, hemoglobin is not actually 100% saturated, but close to 97.5%, which means that there's a potential of increasing the saturations by another 2.5%. And so if we look at the situation of breathing room air, assuming a hemoglobin concentration of 15 grams per deciliter and that it's 97.5% saturated, we come up with an oxygen content of 19.6 mils bound to hemoglobin plus 0.3 mils dissolved in plasma, so roughly 20 mils of oxygen per deciliter. What happens if we increase the inspired oxygen to 100%? In this case, we can bump the saturation up to 100%, and according to the alveolar gas equation, theoretically we can get the PO2 up to 663, which results in 20.1 mils of oxygen being bound to hemoglobin and almost 2 mils dissolved in oxygen. So by giving 100% oxygen, we've increased the oxygen content from 20 up to 22 mils per deciliter. So that's a 10% increase. So it's not a huge increase, but we also can't say that it's completely insignificant. And the majority of that increase is due to dissolved oxygen. From that previous analysis, we would say that giving 100% oxygen would increase the oxygen content in the non-shunt fraction up to 22. What about in the shunt fraction? Well, because the shunted blood is passing an alveolus that's not getting any ventilation, there's no gas exchange occurring, and so that increased inspired FiO2 will have no effect on the gas composition in the shunted blood. It still remains deoxygenated, the same as mixed venous blood. So this is why giving supplemental oxygen can compensate for a small degree of shunt, because we have increased the oxygen content by 10% in the non-shunt fraction. But as the shunt fraction increases, we'll reach a point where this is no longer enough to keep the arterial content above 20. And we can easily calculate when we reach that point by putting the numbers into the shunt equation. So we've got 22 minus 20 divided by 22 minus 15. So 2 divided by 7 gives us a shunt fraction of 28%. So this is why we say that once the shunt fraction exceeds 30%, we are no longer getting a response to supplemental oxygen. So far, we have been focusing on the effects of shunt on oxygen, as clearly the clinical implications of hypoxaemia are much more important than hypercapnia. But sometimes the scope of an exam question does include the effects on CO2, so we should be able to explain the differential effects of shunt on PO2 and PCO2. If we take an example of a 50% shunt and work through the numbers, we can see that the arterial PO2 has been dropped from an expected value of 100 down to 55. But the same shunt has only increased the arterial PCO2 from an expected value of 40 up to 42.5. So why has this shunt caused a reduction in PaO2 of 45 but only increased the PCO2 by 2.5? The magnitude of effect is so different for two reasons. The first reason being that while shunt has a similar magnitude of effect on the arterial content of oxygen and CO2, so a mixed venous shunt will tend to reduce the oxygen content by 5 ml per deciliter and increase the CO2 content by 4 ml per deciliter, so roughly similar. However, because the CO2 dissociation curve is so much steeper than the oxygen dissociation curve, the corresponding change in partial pressure is much smaller. The second reason is that if your arterial PCO2 starts to go up, this should be detected by the chemoreceptors, which would increase your hypercapnic respiratory drive, and this would mitigate any change in the PaCO2. Is shunt just something that they make you learn for the exam, or is it actually important for clinical practice? Well, in my mind, it's actually more important than alveolar dead space. If we first think, what are the causes of shunt? Well, we're saying that shunt is venous blood flow that's going past an alveolus that's not ventilated. So when's that going to occur? That will happen when the FRC drops below closing capacity, which leads to atelectasis and shunting. And this is dependent on both age and position. So anyone who's older than 44 in the supine position or older than 66 in the erect position is going to get shunting. And anesthesia reduces muscle tone and reduces FRC by 15 to 20%. And this is exacerbated by Trendelenburg or lithotomy positions. It's also going to be accentuated in obese or pregnant patients. And there's various pathologies that will also contribute to causing shunting. So we can see that it's going to be occurring in the majority of our patients unless we're preventing it. Shunt is also significant because, in contrast to the other causes of hypoxaemia, a large shunt doesn't respond to supplemental oxygen. So regardless of the primary pathology, if someone's still hypoxemic despite 100% oxygen, then a large shunt must be part of the mechanism. We should also understand that if we suspect that a patient is hypoxemic due to atelectasis and shunting, that the treatment is a recruitment maneuver and increasing the PEEP. And we should be able to explain why this is necessary using Laplace's law. The AA gradient is a useful tool in assessing the degree of venous admixture, and we should recognize that it's only interpretable when the patient is breathing room air, and if they're on supplemental oxygen, then we should instead use the PF ratio. But this is straying more into part 2 territory now. In summary, we can use the three-compartment model to explain why the end-tidal CO2 is generally slightly lower than arterial CO2, and this is due to the presence of alveolar dead space. Similarly, we can use this model to explain why arterial PO2 is slightly lower than alveolar PO2, and this is due to the presence of a small degree of shunt. We should also very clearly understand why a large shunt does not respond well to supplemental oxygen.